The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We've been talking about autism this month with our friend Lisa Palmieri. Welcome back, Lisa.
Happy to be here.
Lisa brings the unique perspective of being practicing a primary care pediatrician who has both interest and additional training in autism diagnosis and care. And I think that brings a very useful perspective, don't you, Lisa?
I have enjoyed the group of children that I deal with, and it's made me, I think, more broad-minded across all my population.
Yeah, it's got to, right? The other part of this, too, is that I think the thing that's so valuable about me having more perspective about this is that I've taken care of these patients since they were infants and, in a way, have access to thinking about a family generally and all the issues that a psychologist may not have and that somebody outside our relationship may not have.
Yes, I agree.
All right. Well, have you developed any disclosures since we last talked?
Still week by week, not a new one, no.
For those of you who have ideas for Lisa to have conflicts, please send your conflicts to conflicts@vcurb.com.
As long as they have monetary support.
No, just conflict. Just edginess. I wanted to talk about some fascinating issues related to autism that I think are extremely important for us to be mindful about. And I'm just going to go through these as bullet points and ask you to expand on them. And here we're talking about issues, relatively high stake, well, very high stakes issues pertaining to adolescents and young adults. So let's start. First of all, let's talk about gender identity issues. Why is this an issue for this population?
I think the studies are still a little bit not firm, but one that I found from 2021 noted that in a transgendered clinic that was giving gender care, 30% of their patients were also identified as autistic. So it makes a lot of intuitive sense to me that people who are neurodivergent would also view their gender and their sexuality as non-binary. So I think that's changed a lot about how I look at the transgendered community and changed sort of my overall support for these children who struggle with gender identity issues. I think it makes it even more heartbreaking when legislation is targeted to transgender people because it's also targeting the autistic population as well. Now, that's not to say that all transgender people are autistic, but a fair number of autistic people are transgendered or non-binary or queer. So targeting these kids is targeting some of the most vulnerable population that already feels socially isolated. I can't tell you how much fear this population expresses online and in clinic with me and to their therapists about their safety, their physical safety from attack.
Well, both that, but emotional safety, right?
Yes.
I think all of us crave to be understood,
Right.
that we want to be acknowledged for who we are and to be listened to.
Right. And again, if you're seeing something through someone else's eyes and you already have accepted that you are not, your brain and their brain aren't the same, it's
Yeah.
much easier to get your mind around why your concept of gender and sexual identity might be significantly different from theirs.
Well, and I think it's also safe to say that it's very difficult to have a conversation if you've never listened.
Correct.
Yeah. Yeah. Let's talk about sexual safety. There are a couple of issues here. You alluded to one of them that we'll come back to, but one of the facts of life is facts of life, right? That as you mature, that having a different set of challenges adds a different dimension to puberty and to everything that comes beyond puberty.
I think one of the common misconceptions, particularly if your patient is both autistic and intellectually delayed, is that sexuality is not an issue. But pretty much across the board, regardless of IQ and amount of autistic behaviors, that person's sexual hormones are changing, and there will be a sexuality that will need to be expressed in some way. Sometimes it's in ways that you don't think in this culture are appropriate or misunderstood by others. Sometimes it's in sexual aggression against the caregiver, pinching, body part of the caregiver or trying to touch the body part of a caregiver. So we kind of bring all of our resources to bear, both to protect the child physically and legally and emotionally, because should the behavior happen to a neurotypical person, there might be legal consequences for the person on the spectrum.
And also, very simple point of view, in a population where sometimes notions of hygiene have to be modeled and explained, how do you deal with periods in
Right,
in
right.
some
And
cases?
and also with the mood changes that occur.
Yeah,
So this is where really frank social stories are really helpful. So it's rather horrifying when you're neurotypical to see somebody talk about how to change a pad with a step-by-step picture. I had one young woman who was having some autism meltdown and slapped a pad, a dirty pad on her head and walked out into the school with it on her head. So we really do need to teach children how to manage this. There's this wonderful thing called period underwear now, which wasn't available when I was younger, but that's made it easier for some of the more higher functioning children to manage. But we also will frequently block menstrual cycles. We'll use norethindrone. I didn't say that right. It's norethindrone, isn't it?
sure.
Okay. 5 milligrams daily can as a progestin only pill. You can't cycle on that, so it has to be taken every single day, but it's a good way to block cycles without increasing the estrogen, which adding the estrogen in can increase feminization. Sometimes your transgender girls, female to male transgender girls that do not feel comfortable with the estrogen, so the norethindrone is good in that setting. We not infrequently will place an IUD under sedation if we are concerned about sexual safety in our young women, both to help block cycles and to make sure there's no unintended pregnancy. And our good friends at the Pediatric Gynecology Clinic have been very gracious at helping us, sometimes on very short notice, getting IUDs placed if the young woman is experiencing or acting out in a way that we think is going to result in a pregnancy.
Sure. What about pornography in this population?
So I don't have any information, but I suspect it's nearly ubiquitous, particularly amongst the population that is gaming. I don't know that as a scientific fact, but I know how much screen time they're on and I know how much they are communicating with others. So I think a lot there is a concern about the amount of pornography that they'll be exposed to.
And you mentioned last time that there are always new blocking programs. And look, things move beyond that, but I think anything is helpful. And I think talking to parents about that can be helpful.
I noticed the AAP just released an app for helping supervise online activity with kids. And so it was just in the most recent AAP throwaway.
I've seen numbers before that I think, coming from a previous generation, this seems alarming, but I've seen NIH numbers that unintentional pornography exposure in adolescents is as high as two-thirds. And I think you're right in gaming communities, but also in anyone with much of an online presence.
Right.
It almost takes an active approach to not be exposed.
My partner told me the statistic that the average age of the first exposure to pornography is age 9.
Staggering, right?
And then if you're looking at a population that struggles with social connection,
Yeah.
they're going to also struggle with how to express the sexuality that they're seeing online
Right.
safely with another person. So I don't have good answers now, but the parents who of these children are supervising at a level that is continuous and exhausting.
Let's talk about another alarming factor, and that's suicidality in this population. What should I know?
So I think probably the thing that we really don't want to miss are the comorbid mental health conditions. So 85% of autistic people have at least one comorbid diagnosis, and 40% have more than one. There are slightly higher rates even of bipolar disorder in this population. So you have to be very aware and screening over and over. As you look at worsening behavior and you're doing your review of systems, worsening mental health needs to be in the review that you're doing. Is there a reason to think this child's mental health is worsening? Are they showing symptoms of mania, like less and less sleep, more and more obsessions? Are they Is the anxiety getting worse? Is the aggression coming because they're so anxious at the end of a school day that they can't unwind? And then failure to treat the mental health issues increases their risk for suicide. So the numbers are anywhere from 2 to 7 times increased risk for suicide. And the real concerning population are those who have impulsive presentation of ADHD in addition to their autism diagnosis. And I had a young man jump from a railway bridge. He did survive, but not without pretty bad pelvic injuries. And I had screened him from a mental health standpoint the week before, and he was screening okay. And we knew he had intermittent suicidality. We'd been watching it come and go. There was nothing to do to have stopped this. So it's something that the parents really fear, particularly the populations, because of the social isolation. When a social relationship falls apart, that may be the only social relationship this child has or this young adult has. So if the girlfriend breaks it off or the social group kicks them out, they don't see an alternative coming up for them. So it really feels like the end of everything.
And so the insulation is information.
No, the insulation is social connection. So all people thrive with social connection and with meaningful activities. And for a lot of people on the spectrum, school isn't going to be a meaningful activity. It's a overstimulating, over demanding place of continuous failure. So we have to really make very concerted efforts, the families and the primary caregivers, to try to make sure this child has outlets that are positive for them. I think there's a couple of misapprehensions, and one of them is that autistic people don't want friends. There are a few people who really, truly are fine with complete social isolation, but I would say the majority of autistic people want friends. They just want friends that understand them, like all of us do.
Sure.
The other miscomprehension is that they're all STEM interested. So there are certainly well-known people who are good at math and science, but there is a high interest in the theater and performing arts. And that's often a group where diversity, neurodiversity is welcomed and celebrated. So a number of my kids who don't like school at all will go if they can be part of the theater production.
Mhm. Yeah, and also, as I understand it, many artists who would self-identify as being autistic, and I think
Right.
having that insight is an important thing.
And then using that insight to help build connection. So, because autistic people have intense interests, when those intense interests are shared with another person, connection develops. So, D&D groups, art groups, theater groups, whatever you can do. And sometimes you have to kind of take your time and throw lots of different options out because the kid says no to everything. But
Sure.
eventually they'll try something.
I think we all have an intuitive sense of this. What about bullying? How do you help with that?
I think the schools, of course, are quite receptive now, almost across the board. I've seen situations where that is really not true. But I think nobody wants a mass casualty event, and so they are trying to identify bullying. I think the only way you bully proof the child at school is to make sure they have a group that will stand by them. But even then, it's difficult. So I think it's something that you ask about when you see worsening mental health and worsening aggression.
Sure, it's a tough conversation to have, isn't it?
And I'm afraid that most autistic people will say they have been bullied at some point in their life. I don't know any numbers, but just based on my reading and some autobiographical reading, it seems that this is a pretty universal experience for them
And living in the world.
living in the world. Yeah.
Let's talk about the risk of encounters with law enforcement. How is that an issue?
So, because behavior is not neurotypical in autistic people, sometimes they're seen as threatening to others. They are less likely to respond to commands to do something, such as, raise your hands or lay down on the ground. They don't do it less for law enforcement than they do it anywhere else, but they don't like that. That feels highly aggressive to somebody on the spectrum. Often law enforcement's called in to find a kid who's run away or whose behavior is increasingly aggressive at home. And we had a really sad encounter here in Salt Lake City a couple of years ago with a mom who called for help with her 13-year-old, and the 13-year-old ended up being shot dead. So she was just calling for help managing his aggression. It's somewhat in response to this. The pediatric groups in Utah developed something called the Stabilization and Mobile Response Unit, called SMR. And its phone number is 1-833 SAFE FAM, FAM. And this is a team that will mobilize to your home and help with an aggressive or out of control kid, trying to keep law enforcement out of the picture and keeping the child out of the emergency room as much as possible. So these are trained therapists who come, who do a therapeutic intervention at the scene. So they will do actual therapy right there, not just talk to the child or talk them down, but actually do some therapy. And then they make sure that resources are in place moving forward, including emergency access to higher levels of care as needed.
You also mentioned offline the possibility of making an introduction.
Yeah, so we encourage that actually as far as making an introduction to law enforcement all the way down in our toddler age group. Our toddlers with autism are known to wander. There is some data to suggest they're particularly drawn to bodies of water. So we ask families to identify the bodies of water around them, and then we hand them a form called an elopement form with a photo of the child and all the things, sensory things that the law enforcement team would need to know. Like, can the child be touched? Are they verbal? What kind of hiding places would they prefer? What sensations are going to be upsetting? And then that's handed to law enforcement when they arrive. And then we also recommend they take the child down to law enforcement to introduce them to law enforcement so the local police station knows that you have a kid who goes walkabout or who has aggressions. Parents have said that's been very helpful. The police department knows this kid now. They know not to challenge him. They know how to respond and what the parent says works the best. So parents have really utilized this behavior to improve the safety of the interaction between an autistic person and law enforcement.
That's a great idea. And with working through relationship building rather than fear and mistrust. Let's talk about independence and emancipation. What do we need to know there?
I think as we work with our young adults, sometimes our late teens and young adults, we forget that there's often a pretty big desire for independence, particularly those that are higher functioning. The desire for independence may be bigger than the adaptive skills. And so that can be a source of severe frustration and anxiety for the young adult who sees other people his age driving or getting a job or moving out, and they still feel dependent. So that needs to be explored into which ways this child can improve his independence and what other skills he can practice, from, teaching him how to manage a bank account to helping him learn how to get groceries and do basic food preparation. But again, it's highly frustrating to have a fairly normal IQ, but adaptive function that's poor enough that you know you can't move on like your peers.
What kind of resources are available to autistic adults?
So there's a lovely place called Scenic View Academy that's located in Utah County that is a very small private college for people on the spectrum. You can only go there if you are graduating without a diploma. So if you're graduating with a diploma, it's not for you. If you're graduating with a diploma, there are some other supported college scenes. Scenic View has a lot of scholarship available, and they work on a supported college campus Kids can live in dorms and they work on activities of daily living. And it's been a highly successful placement for one of my kids who is thriving in that environment. And she's able to have some of the college experience, but in a much more supported way.
In closing, let's talk a little bit about the neurodiversity movement in general. What can you tell me about the neurodiversity movement? We've talked a little bit about identity issues over the past couple of weeks, but what should I know?
So, this movement is birthed out of the overall movement for increased rights for people with disability. And the neurodivergent population has moved as part of this movement. So, in general, the disabled community wants more visibility and equal opportunities. And the neurodivergent community is asking for the same things for themselves. I think a couple of things to know, and some of it I didn't really know till I was researching for this, but they don't like to be referred to as people with autism. Many of them prefer to be referred to as autistic people. That's very counterintuitive to what we've been taught, not to call the child with Down syndrome versus a Downs kid. That is not acceptable. A Downs kid is not acceptable. A child with Down syndrome is. But the autistic community, some of them feel that autism is such an important part of their identity, and it's an identity that they're embracing, and that they don't really feel they need to look less neurodivergent in order for neurotypical people to feel comfortable. And I think that's asks those of us in the neurotypical community to be more open-minded. And if you see someone who is neuroatypical, to accept them as a peer and as another person rather than as a person with something disabling. So the neurodivergent community is really starting to demand more respect as people and more opportunities and accommodations in work settings and social settings.
How do we make sure that we are, as I guess, both as physicians as well as just in daily life, that we have the right welcoming and adaptive attitude?
I think you had mentioned it earlier is listening is the primary way to do this. People know when they're being listened to. Autistic people want to be asked what their pronouns are. They want to be asked how they identify. They want to be asked about how they see their autism affecting them and what they like about it. There's any number of my patients who will talk quite openly about autism and why they like it and how they don't want it to be different. So when they feel that way about themselves, then I have no business trying to make them into something they're not. Finding out what their goals of treatment are, respecting their goals of treatment as legitimate goals as long as they're safe, is, I think, probably the key to forming bonds, particularly with late teen and young adults. So sometimes our goals might be, okay, we want to learn to ride the bus by ourselves because we want to go to a D&D club that we can't make it to, or we want to make it to the LGBTQ support group, and that's going to be our goal. Or for one kid, it was like, we're going to go to the bookstore one time this month. And that was a goal that child wanted, loves the bookstore, felt like that was a goal they could achieve. And so making goals that are patient derived is going to be much more successful and also much more respectful.
Yeah, I mean, it's human nature, I think, sometimes to see the way I do things, the way I feel things, the way I see things as the right way. And it makes the world a much less interesting place if I come to life with that sort of condescending attitude.
And I think also just celebrating differences. I think the more we
Yeah.
celebrate all the differences, the cultural differences, the learning differences, the sensory differences, the intellectual differences, the more diverse of a community we have, the richer of a community we have. The neurodivergent movement is using the phrase, nothing about us without us. And that is also from the disability community. Autistic people really want to be the leaders of their own conversation. They don't need neurotypical people helping them out of their autism.
That seems like one of the least audacious things that anyone could ask for.
The least audacious, like, could I just be involved in my own management?
Yeah, yeah. Because let's be absolutely honest. If everyone in the world is exactly like me, it's a very boring place.
Yes, yes.
All right. Well, thank you very much for this conversation this month. There's been a lot to think about. I'm sure there'll be questions. Please send questions to questions@vcurb.com. We'll talk about that next week. But this has just been, I think, extraordinarily rich to be able to talk with you about this. Lisa, thanks so much for your time and expertise. And thanks to Lisa Stoddard for making this sound like a podcast. And thanks, Janice, for listening. We'll come back next week with some questions. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Lisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.